Hello, my name is Seo at Asan Medical Center, Seoul, Korea. Stones can be developed at any site of the biliary tree. Among the biliary stones, intrahepatic stones may be the most difficult one to control. In case of stones localized either right or left intrahepatic duct, surgical resection can be a good treatment modality. However, in a patient with multiple bilateral intrahepatic stones, cholangioscopic stone removal can be a good therapeutic option. Cholangioscopic approach can also be applied to difficult common bile duct stones which are not removable by conventional duodenoscopic approach. Today, I'd like to provide you a series of videos showing several techniques of cholangioscopic stone removal. Let's start with the basic techniques of stone removal from the bile duct. Basket stone removal may be the most commonly used method for cholangioscopic stone removal. For this technique, a basket should be introduced into the bile duct through instrumental channel of cholangioscope. An optimal location of basket before opening may be just behind the stone, and open the basket at the posterior side of a stone. A gentle pulling movement can engage the stone inside of a basket. After engagement, further pulling of basket is necessary to hold the stone tightly, and then the cholangioscope with the stone holding basket can be removed simultaneously. These are black colored stones removed from intrahepatic duct. If a basket is opened in front of a stone, there is a possibility of stone migration into peripheral duct. Vigorous basket movement, especially rapid to and fro movement of basket, can cause deformity of basket. When a large stone is fragmented into small pieces, while small stones are located in the peripheral duct, normal saline irrigation can be a very effective way to remove all the stones with sludge material. If we try to remove all the pieces by repeated basket use, it would be labor-intensive and time-consuming procedure. When the stones are located in the dilated terminal branch duct, basket stone removal can be very difficult. The shape of basket is easily deformed because there is no space at the posterior side of the stone. If we inject normal saline forcibly into the terminal duct, it makes a whirling movement of stones, and sudden retraction of the cholangioscope causes outward flow of normal saline from the bile duct. Small stones and debris can come outside of the body with this flow. Another important application of irrigation method would be removal of stones located in an angulated duct. The stones are not clearly visible. However, small stones and pus material can be drained effectively by saline irrigation. It is not necessary to remove all the stones outside of the body. When the ampulla or choledocho-enterostomy site is patulous, small stones can be pushed into the duodenum or enterostomy site instead of removal from the body. This technique can be called as cholangioscopic pushing method. By this technique, small fragmented stone can be effectively pushed from the CBD to the duodenum in a short period of time. For this technique, the distal common bile duct and ampulla should be patulous. In a patient who have received previously endoscopic sphincterotomy, this technique can be applied without difficulty. However, in a patient whose sphincter muscle is intact, percutaneous antegrade balloon dilation followed by catheter placement for 2 or 3 days is required. Cholangioscopic pushing method comprises 2 components. The first step is engagement of small stones into the far distal CBD, and the second step is pushing the stones into the duodenum by exerting mechanical force to cholangioscope. Once ampulla becomes patulous and stones are fragmented into small pieces, It is not difficult to push small stones into the duodenum by cholangioscope. The mechanical force should be exerted to the direction of bile duct opening. Excessive force to the cholangioscope can cause damage at the tip of cholangioscope. When the size of stone is larger than that of percutaneous tract, it cannot be removed at once. Large stones should be fragmented before cholangioscopic removal. For stone fragmentation, electrohydraulic lithotripsy or laser lithotripsy is commonly used. For EHL, the metal tip or probe should be targeted on the surface of a stone, and firing should be done only after appropriate location of the tip. The intensity and frequency of shock wave can be modified according to the hardness of the stone. After firing, the stone debris and sludge material make the visual field very poor, so saline infusion is required to get a clear cholangioscopic view and to irrigate small debris. It is critical to ascertain the proper position of EHL probe so as to avoid ductal injury. This black-colored stone has very hard outer shell, and it is not easily fragmented by several EHL firing. Although the targeting seems to be appropriate, reddish bile duct wall injury is developing at 10 o'clock position by repeated generation of shock wave. In this situation, my approach is to target only one point of the stone repeatedly and reach to inner core as early as possible. After exposure of inner core of a stone, further lithotripsy becomes much easier. Another important application of lithotripsy is to impacted stones. This stone looks like a small stone. However, when we see a cholangiogram of this patient, it becomes evident that this is a small anterior portion of an impacted large stone. When a stone is impacted, basket removal becomes very difficult. A basket cannot be passed over the stone, and the irrigation method is not helpful. EHL can be a powerful tool to overcome this difficult situation. Now, I am going to talk about how to find out missing duct or stones. Understanding of segmental anatomy of intrahepatic duct is very important for the removal of intrahepatic stones. Intrahepatic stones frequently accompany multiple strictures, and because of this stricture, a problem of missing duct can happen. This patient shows multiple stones in the left intrahepatic duct and gallbladder. After removal of left intrahepatic stones, this cholangiogram reveals no residual stone in the intrahepatic duct. However, when we review the CT scan of this patient, there are stones in the right anterior segmental duct as well as left intrahepatic duct. Upon previous cholangiography, right anterior segmental duct is missing. In order to find out the missing duct, the tip of cholangioscope is located at the presumed origin site of right anterior segmental duct, and then forceful contrast injection was done. Now the missing duct is faintly delineated. Careful review of imaging studies and three-dimensional understanding of segmental ductal anatomy is an essential step for complete removal of intrahepatic stones. Another important clue to find out hidden stones is a pus draining sign. This patient shows linear strands of pus at the stricture site, and the stones are not clearly visible. However, this sign indicates that there are some lesions upstream to the stricture segment. If we insert a cholangioscope into the stricture segment after stricture dilation, we can find out hidden stones. Finally, I'd like to emphasize another important point. Cholangioscopists should think about which is the best therapeutic strategy. In this patient, there are a lot of large stones in the right and left intrahepatic duct, and common bile duct. Common bile duct is poorly delineated because of huge stones. In this patient, we can try basket stone removal from right intrahepatic duct, and then left intrahepatic duct, and finally common bile duct. However, this approach would take a lot of time, and the number of cholangioscopic sessions would be increased. My advice is firstly to proceed to the distal common bile duct and ampulla as early as possible using lithotripsy and irrigation method. Secondly, dilate distal common bile duct and ampulla using 8 to 10 mm balloon, and then keep an 18 French PTCS catheter into the duodenum for 2 or 3 days. In the next session, the fragmentation of common bile duct stones should be started from the distal side of CBD, and then small pieces of stones can be pushed out into the duodenum through the dilated ampulla. This approach can be highly efficient and can reduce not only the procedure time but also the number of cholangioscopic sessions. I hope this video may be helpful to those who deal with intrahepatic stones and difficult bile duct stones. Thank you.